Good morning or good afternoon, dear colleagues. I'd like to thank the organizing committee for inviting me to this meeting. My topic will be new data from combination trials for HPV. These are my disclosures. This is the methodology of my lecture. I looked through the PubMed. I searched the ACLD 2021 abstract, including all the late breakers, both oral presentations and poster presentations. I have sent dedicated emails to all the HPV companies involved in this business, and I will concentrate on S antigen decline and loss. I will not cover combination strategies that do not achieve or do not show promising S antigen loss or decline. So we all agree that the endpoint of therapy is functional cure, defined as sustained and detectable S antigen negativity and DNA negativity with or without anti-S. And this is the most important really endpoint for any new therapy. I like to remind everybody that functional cure means off therapy, and we cannot use this terminology during therapy. Eventually, we will use S antigen loss during therapy. To achieve S antigen loss or functional cure, we have to really change the strategies that we are using for hepatitis B, going from the current strategies aimed to suppress viremia based on long-term oral therapy to new strategies aimed to clear S antigen and, of course, clear or suppress viremia. Strategies based on short-term combination strategies. And the achievement of functional cure could be very, very important, not only to shorten duration of therapy in patients never been treated so far, but also, for example, to treat many more patients, potentially patients that so far have not been treated with hepatitis B drugs, potentially try to reach W targets, and for nuke suppress, stop oral therapy safely and potentially to reduce complications such as hepatocellular carcinoma. I mean, there is a lot of background and rationale for achieving S antigen loss. There are many drugs potentially available. Many drugs can be characterized as direct antivirals, and here you see a scheme with all the possible drugs tackling different steps of viral replication, entry or egress of S antigen, and many other drugs that could potentially use to stimulate the adaptive immunity or the innate immunity. But drugs are not enough. We need to define strategies by which we should use this drug. And the overall idea, at least so far, is that to achieve a functional cure, which means S antigen loss, we might be able to put together 3 different strategies or drugs with 3 different mechanisms of action. Potent inhibition of viral replication, potent inhibition of viral antigen production or egress, and immunomodulation. Today, I will not cover all the combinations like CAM plus nuke that did not show any specific S antigen decline or significant S antigen decline. But I will cover studies that are considering the possible combination of potent drugs inhibiting replication and inhibiting viral antigen production. One example, for example, is the GSK836, which is an example of antisense oligo. This is a sub-Q drug which has been given for 4 weeks in this specific study, which has been recently published in Nature Medicine 2021. And this is supposed to be to stop all the RNAs, viral related RNAs into the cell, both in the nucleus and also into the cytoplasm. And I will concentrate in the combo arm of the study. This drug was used as an add-on strategy in the 2 patients nuke suppressed who got placebo, no changes as expected of S antigen. In the 4 patients, very limited number who got this drug as add-on on the top of nuke, 1 showed no changes of S, 3 had a significant decline of S, approximately between 3 to 3.5 logs. So the first question is, Why we did not see any change in one, while significant changes in the other three? That's something not clear, at least to me right now. The second very important point of the study, on the top left of the slide here, is that these three patients achieve a significant decline of S, defined as a red line. In two cases, they became negative. The third case, almost negative. But in all the three cases, they had a rebound of S of therapy. But there is another very important point, actually 2 points. One, a significant decline of S in all three cases. The second, a significant flare after the S antigen became negative, or after the S antigen became very low, let's say below probably 10 units. This is absolutely a unique situation that was not observed in patients treated with the placebo, of course, or in patients not responding to with S antigen decline. So very interesting add-on combination with this new drug, with the safety profile did not show any major problem. There is another possible strategy that you could use. It is a VIR-3434. Is a new HPV neutralizing antibody with multiple potential mechanisms of action. One, inhibition of viral entry. Two, cross-presentation to T cells, a stimulation of T cells, and potentially a clearance of S antigen and delivery to the dendritic cells. At the American meeting that will start in a really few days, there will be a very important presentation on this specific study. This is add-on strategy of VIR-3434 in nuke-suppressed non-cirrhotics e-antigen negative patients with S antigen below 3,000. This is a randomized study in which they use two different doses, 6 milligram or 18 milligram, or versus placebo with a single injection. That's very important, a single injection add-on strategy. And 10 of the 16 patients, 62%, achieved more than 1 log reduction. And this was particularly true in patients treated with 18 milligram compared to the 6 milligram. But the other very important point is here, shown in the graph on the right-hand side of the slide. One single injection led to a 1.5 decline of S antigen with 18 milligram, maybe something less with 6 milligram. After this profound decline, there was a plateau phase, and then a rebound phase in many patients, but not in all patients. Some of the patients, S antigen remained 1 or 1.5 log lower compared to baseline. So potentially very interesting study. Again, this is a phase 1 study with a single injection in combination with nuke. There is another possible strategy, which is nuke plus CAM plus siRNA. So 2 drugs to stop replication, 1 to stop antigen production. And this is probably one of the most important studies that I think will be presented at the American meeting in a few days. This is the phase 2 REEF-1 study, the 1-year data at the end of therapy. This is a very important study for several reasons. First of all, it's a large study, almost 500 patients being randomized to 6 different arms. And the arms are included here: nuke monotherapy, nuke plus CAM, different doses of siRNA plus a nuke, and a triple combination therapy, nuke plus CAM plus siRNA. And the primary endpoint of the study is a rather unique primary endpoint. First of all, is at the end of therapy, is not off therapy. Second is a combined endpoint. You see here on the left side, primary endpoint was defined as the combination of low LT, negative DNA, negative E antigen, and S antigen below 10. So a kind of strange, if you wish, primary endpoint, which was aimed to identify patients that could potentially stop therapy. Well, the first very important point of the study is here down below the graph. Only less than 3% of the patients achieve S antigen loss. So very limited S antigen loss during therapy. The second very important point is represented in the graph. That's the primary endpoint, again, combined endpoint. including different variables at week 48 at the end of therapy. Basically, no response in the nuke monotherapy or nuke plus CAM, and a progressive increase of the proportion of patients who achieve this endpoint, going from 40 to 100 to 200 milligram siRNA plus nuke, sort of de novo combo or add-on strategy, from 5% to 19% achieving primary endpoint. But probably the most important information is this group here. In this group is a triple therapy, SI, CAM plus NA. 9.4% of the patients achieve the endpoint, compared to 16% of the patients with 100 milligram siRNA plus nuke. So double combination versus triple. Apparently double is doing better, and the reason why the results are better is mainly related to the S antigen decline that was more profound in the double combination arm compared to the triple combination arm. So very important point. From my point of view, I don't have a specific explanation. To my knowledge, it's the first time that we have less S antigen reduction of less primary endpoint with triple combination compared to double combination. There is another strategy which I think potentially would be the best strategy: combine all the pillars together: strong inhibition of viral replication, strong inhibition of antigen production or release, and immunomodulation. One possible strategy is use nuke plus siRNA plus PEG interferon, and this is a very nice study which has been presented in preliminary form at EASL 2021, so back in June this year. This is a study looking at the siRNA VIR-2218 in combination with PEG interferon and a nuke. Some of the patients, cohort 1, they received nuke plus siRNA. Cohort 2, they received a triple therapy, but PEG was added at week 12, a delayed add-on. Cohort 3 was really a triple therapy from the beginning: nuke, PEG interferon, and siRNA. And the final result of the first 24 weeks of therapy will be presented in a couple of days at the American meeting by MFUN. Again, this is a very important study, again, in non-cirrhotic, virological suppressed or nuke suppressed chronic hepatitis B patients. 48 patients were enrolled in the original study. These are preliminary analysis in 22 patients. On the right-hand side, you see the most important information of the paper, showing the S antigen decline in this nuke suppressed patient, comparing 3 different strategies. VIR monotherapy, which means siRNA monotherapy, progressive decline of S, 2-log decline, exactly the same decline observed in the VIR siRNA plus PEG interferon delayed. Delayed mean as an add-on at week 12, so really no advantage. The best strategy was the triple combination from the beginning: nuke plus siRNA plus PEG alpha from the beginning, with a significant decline of S up to 3 logs in 24 weeks, which is very significant difference, mainly at the beginning of the 21st 12 weeks. This was associated with significant elevation of LT levels when this was associated with reduction S, and I think we have to manage from now. We have to kind of learn how to manage these LT levels in these studies leading associated with S antigen declines. So this potential strategy could be very, very interesting. But there is another strategy, again, that could be a nuke plus SO, antisense oligo, plus PEG interferon. I'm not going to present you the data of this study, but just to make a point that many companies, this is just one of the companies, is really looking into this triple combination, even in sequential way. This is the B to get a study design, including more than 100 patients that will be randomized in 2 different arms. So GS836 for 24 of 12 weeks, followed by PEG interferon. In the context of long-term nuke therapy, the primary endpoint will be at week 72 or 6, define a sustained response. I would make the point that this is not really sustained because all patients would be on nuke therapy. I would really ask the companies not to use sustain for responses during a nuke therapy, please. But there is another possibility. Another possibility is try to target viral inhibition by using different drugs with different mechanism of action. I'm not showing human data, but I'm showing this study, which has been presented at EASL 2021, but also will be presented also in a couple of days at the American meeting. What they did in this company, they look at the in vitro model combining antisense oligos plus siRNA, and they were able to show some synergistic effects. So two different mechanisms of interfering with the viral RNAs. Also, they were able to show in vitro a synergistic effect by combining ASO and stops. You know, stops is working as a NAP, means stopping the egress of S from the cell. And they also look in the mouse HPV model. They show the progressive synergistic effect of the S antigen decline by combining the siRNA and the antisense oligo, compared to either one as a monotherapy. And in the American meeting, we also see another study where they also use PEG interferon in this combination. Again, PEG interferon now is becoming very popular. Another strategy that could use a new combination strategy to combine drugs being able to stop viral replication and immunomodulation without any drug specifically, targeting antigen production. But interferon is not the only immunomodulator. This is a very interesting study, again, that will be presented at the late breaker abstract in a couple of days from China at the American meeting. This is an interim analysis of the phase 2B clinical trial with this ASC22, which is sub-Q PD-L1 antibody in nuke-suppressed patients. So it's the model nuke-suppressed add-on an immunomodulator. And this is based on the fact that the blockade of PD-1 or PD-L1 pathway may lead to functional cure. This ASC22 is a humanized single-domain PD-L1 antibody. This is a large study. It's a phase 2B in almost 150 chronic hepatitis B patients negative for the antigen. All these patients were fully nuke suppressed. It's a 24-week study. Now I'm going to show the data from the first 75 patients. What they were able to show is that in a subset of patients, 16 patients with S antigen below 500, they were able to show a significant more than 0.5 log decline of S. And please remember, 3 of the 16 patients achieved S antigen loss in only 24 weeks of add-on strategy. These 3 patients are highlighted on the top right of this graph here. Patient number 1 achieved S antigen loss in 4 weeks and remained negative. The number 2 in 16 weeks and remained negative. The number 3 patients 60 weeks and remained negative. The first 2 patients had an LT flare, not a major LT flare, a significant flare, coincident with an S antigen decline, we see here, and you see the other one, but not the last one. The last one, you see, these are 30 units. He or she had no ALT increase. So potentially very interesting. The drug was administered every 2 weeks, but given the pharmacokinetics data, potentially this drug could be administered once a month and no major issues in terms of safety. So potentially, finally, a new immunomodulator for hepatitis B. So in summary, ladies and gentlemen, we all agree the new endpoints in HPV therapies is functional cure, as antigen loss. In my view, combination strategies involving antigen reduction inhibition are required, or even antigen egress inhibition. S antigen must be the target of these combinations, where we can discuss integrated versus cDNA, maybe the good S antigen, maybe the bad S antigen, subviral particles versus virions, and so and so. And the new combinations involving siRNA, antisense oligos, monoclonal antibodies may induce a multi-log decline of S antigen in few weeks. So excellent results. Surprisingly, at least for my knowledge, the triple combination nuke plus clamp plus siRNA was not superior to the double combination of nuke siRNA in terms of S antigen decline and in terms of primary endpoint for the RIF1B study. For sure, PEG interferon alpha is back into the game. Many companies use it with, in my view, pros and cons. Many cons when we go from randomized controlled trials, phase 1-2 to real life. Overall, unfortunately, so far, S antigen loss rates with new combination therapy are still limited. But I'd like to make a point. Companies are now using two different strategies. This is something that we have to consider. Some of the companies are using these new combination strategies to achieve S antigen loss during therapy. Other companies have a completely different approach. They are using these strategies to achieve off-therapy functional cure, and I think these two strategies are different with different pros and cons. Thank you very much for your attention.